good afternoon, everyone, and welcome back to the Brainy Boomer Lecture Series. We're so very happy that you've all joined us today. We would like to begin by acknowledging that the McGill University Research Center for Studies in Aging is located and our work is done on unceded Indigenous lands. The Kanien'kehá:ka Nation is recognized as the custodians of the lands and waters on which we gather today. Tiohtià:ke, commonly known as Montreal, is historically known as a gathering place for many Indigenous peoples. Today, it is home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future, and our ongoing relationships with Indigenous and other peoples we serve within the Montreal community. In 2007, the McGill University Research Center for Studies in Aging Education Committee started the Brainy Boomer Lecture Series in order to suggest practical steps to both improve and maintain brain health, as well as to promote healthy lifestyle choices amongst the most populous generation in history. The MCS SAGE Education Committee, which was founded in 1996, has three main objectives: identifying education needs of healthcare providers, seniors, caregivers, and the public, and developing responses to meet some of their needs; to enhance the positive image of the aging process by addressing stereotypes and myths about aging; and finally, the dissemination of research on aging. Stefania Polymeris is a physical therapist who obtained her Bachelor of Science in Physical Therapy in 2016 at the University of Patras in Greece. She received her Master's of Science in Rehabilitation Science with a thesis centered on neurological rehabilitation and neuroplasticity of the brain. Stefania keeps up to date with the latest literature concerning physiotherapy by being involved in research and teaching at McGill University. During her graduate years at McGill, Stefania won multiple awards for her research and had the opportunity to present her work at the World Stroke Congress, the Canadian Stroke Congress, and the Quebec Congress in Adaptation Rehabilitation Research. She also won a travel award to pursue continuing education at the University College London in the UK. Before continuing, we would like to remind you to please keep your microphone on mute during the presentation, and that if you have any questions, you can either write them down in the chat box on Zoom or wait until the end of the presentation to ask them directly. And now I'd like to invite Stefania to start her presentation.
Thank you, Caitlin. Good afternoon, everyone. Thank you for being here in the presentation. As Caitlin mentioned, my name is Stefania. I'm currently a physiotherapist here. I work at DYNAMIK, and I'd like to talk today about multiple sclerosis. My question was, is it a treatable disease? I find a lot of people have been mentioning lately in my clientele that they've either been diagnosed with multiple sclerosis or they know someone around them who has been battling or dealing with multiple sclerosis. I thought it's a topic that would be interesting to talk about. So I'm going to start. So let's start a little bit with what is multiple sclerosis. I'm going to talk to the general public. I'm sure we have some clinicians or healthcare professionals with us too, but I'm going to try and make it as easy as possible. It is a chronic disabling condition, right? So we're talking about the central nervous system. As my roots are Greek, as Caitlin mentioned, I wanted to define the word sclerosis, which is sklerosis, which means hardening, right? So it does refer to the plaques of the central nervous system. These plaques or lesions are areas of inflammation and destruction. And usually we're talking about areas of the brain. And this destruction occurs in the myelin sheath of nerve fibers, which leads to loss of axons in the brain and the spinal cord. So I have put just a little picture here for people to be on the same page when we're talking about nerves, axons, nerve fibers, and etc. So this would be the myelin sheath. I think you can see my mouse. Correct me if I'm wrong, Caitlin. But I'm showing this is the myelin sheath. This is the actual cell body of the nerve. And this would be the axon, which is covered by the myelin sheath. Thank you. So what happens is this myelin sheath starts to get destructed, and then any stimulation that is sent through these nerves is not well sent, and we have destruction of the signal of the nerve. Some areas that multiple sclerosis tends to affect is vision, and usually that's one of the first areas, so it does affect the optic nerve. So people with multiple sclerosis at early stages tend to have some blurry vision, or they have a little bit of a double vision, or they can't see properly. Then we go to sensory what do you call it, sensory feeling. So basically they can't really feel that well. It starts affecting the muscles, so they get weaker, they can lose their balance, they cannot walk properly. Then we're talking about the urinary system, digestive system. This is not really my field of interest, as I am a physiotherapist. So I'm talking more about muscles, I'm talking about the sensory stimulation, I'm talking about spinal cord, and whatever damages we see in the brain. So I was talking before about the myelin destruction. This would be a healthy neuron. So we see here all the myelin intact, the signal is transported correctly, we get a lot of signal here and stimulation. Whereas here, we can see that the fibers of the axon are starting to get exposed, the myelin is being destroyed here or damaged, and then the signal starts to be disrupted. So we don't get the same stimulation and sensory signal from the brain. And this is when, for example, as we can see here in the picture, we don't have a good sensory sensation, we don't have good muscle control. So we could just easily just drop a cup of coffee without being able to have an explanation for that. And that would be little signs that we could see when we're starting to talk about multiple sclerosis. So the two things to watch out for would be vision, and then like clumsiness or falling down the stairs for no reason, or dropping a cup of coffee at some point. You feel that you don't have enough strength for it. So all these little signs and symptoms are to look out for when we're talking about multiple sclerosis. So I mentioned before, I'm listening about it more and more often, but let's see, like in literature, what we're talking about when we're talking about epidemiology of multiple sclerosis. Around 2.5 million people worldwide are estimated to have multiple sclerosis. And this distribution of disease varies among geographic regions. What does that mean? That usually people live in the northern United States, in Canada, Europe, New Zealand, and Southern Australia have seemed to be particularly more affected. In some parts of Canada, as I want to focus a little bit more in Canada, the rate is as high as 385 per 100,000 people. However, if we look into like the Inuit people of Canada and Alaska, they do tend to rarely develop MS. Could it be because of weather conditions? Probably. We don't have an exact explanation why this, but it could be related to weather conditions, cold weather, or etc. Initial symptoms of multiple sclerosis usually appear between 20 to 40 years of age. So if we're looking at a person who is post 60 years or before 15 years of age, it probably won't be multiple sclerosis. We have to look for something else. Women are more likely to have multiple sclerosis than men, and it also strikes later in life. And when we're talking about older in age, the sex ratio is more even. So for example, if we're talking about someone in their late 40s, we don't really see a difference between men or women. The average age for MS diagnosis in women is around 29 years of age, whereas men is a little bit older, 31 years of age. Let's see now what we know about the known causes of multiple sclerosis. What could cause this? The leading hypothesis is that it occurs to people who are genetically susceptible to the disease, meaning that they have experienced some type of environmental assault, such as exposure to a particular virus or toxin. We have found in the literature that talking about viruses, the most correlated one to multiple sclerosis is the Epstein-Barr virus. This causes an infection, mononucleosis, Okay, this has strongly been linked to multiple sclerosis throughout the years, as its plagues express high levels of Epstein-Barr virus antigen. So when we're talking about people who have been diagnosed with MS, we usually do see that in their plaques, they have been exposed to the Epstein-Barr virus. Other factors that could also be linked to multiple sclerosis could be autoimmune diseases such as thyroid disease, type 1 diabetes, or inflammatory bowel disease, IBS. On the other hand, we're also talking about environmental factors, as I mentioned before. So we're talking about low levels of sun exposure and vitamin D, people who tend to smoke a lot, obesity, and high levels of salt consumption. Let's see what we see in symptoms of multiple sclerosis. They are highly variable, so we can't really say, someone who has multiple sclerosis is for sure fatigued or for sure has some type of paralysis. But we can also say that, we do see a lot of people who have single symptoms or combination. And we have a difference in these symptoms, so they can arise as sudden attacks, or they can progress steadily. We will see the type of multiple sclerosis too. So most people with multiple sclerosis tend to have fatigue. In 70% of cases, we do see people that have a lot of fatigue. We do see that they have unusual sensations. So we're talking about paresthesia, tingling, pins and needles. We see muscle stiffness or spasms. So what I mentioned before, like you can just be holding a cup and you drop it because you don't have that correct sensation, or your muscle is really stiff and it can't actually grasp the mug. We see that people have tremors, dizziness, numbness, weakness. As I said before, IBS, paralysis or gait disturbances. They can also feel dizzy. That could either be because of visual abnormalities. As we mentioned, it does tend to hit the optic nerve. Or it could be something like a cerebral imbalance. It has affected the cerebellum and it tends to make them more unstable and have disturbances when they're walking. They also hits their speech, so they could have slurred speech. And then we're talking about more cognitive deficits, so they could have memory problems, their attention is very reduced, and they have difficulty with solving problems. So for example, if we give them a math problem, they can't actually grasp that problem and solve it. And obviously people who are dealing with all these issues tend to have a lot of depression and mood swings. Let's see a little bit the types of multiple sclerosis. So multiple sclerosis usually starts with an acute episode. So as I said, you could maybe fall down the steps, or you have this blurry vision, or your eye is not working properly. But then exhibits varying degrees of remission and progression, okay? So the first one we're talking about is relapsing-remitting. This is the most common form. That's why I put it first. It does occur in about 85% of multiple sclerosis patients. In this case, we do see flare-ups of symptoms followed by a period of remission. So people who have multiple sclerosis, they might have a few weeks that they can't really do much. They feel very fatigued, very weak, very dizzy, are confused, they have blurry vision. And then here comes the period of remission that they feel that nothing's wrong. They gain back their strength, they have their balance, they can go for walks, and it's like nothing's happening. Then I'll go through the rest pretty fast, and you can always look back at my slides if you want to get more information. We have the primary progressive one. This is by gradual worsening of symptoms, and we don't usually see periods of remission. So we just see a declination in symptoms, the state of the person, but it's not very common. It's around 10 to 50% of MS patients. Secondary progressive, we see that when the relapsing remitting MS converts to a course of gradually progressive disease. So again, we don't really have much of a period of remission. This is 90% of relapsing-remitting multiple sclerosis people, and they do eventually tend to develop this type after 25 years. So living with MS for 25 years, then we startly see quite a fast progression of the disease. Then progressive relapsing, these, again, we don't really see a period of remission. The disease symptoms worsen progressively from onset, but also the patient, we do see that they do have distinct attacks or relapses. So they could be progressing slowly, and then at some point they have an attack and they become worse with time. These are pretty rare, and we only see in usually 5% of patients. Then we have clinically isolated symptom. This is a single symptomatic episode. It could last up to 25 hours. And this could be like a precursor that someone might develop MS, or it's just telling you that you might have another type of disease. So it's more like an alarming episode for people to be aware. The benign one, this is like near total remission. So you don't really have much of an accumulation of disability. Asymptomatic here, as the word says, we don't really see any symptoms. So here we want to see that mostly we detect the incidence from an MR examination or during an autopsy, but we don't really have clinical indications. So as physios, we can't really evaluate and see what's going on because we don't really have a clinical image of these MS patients. And last one, the fulminant one, this is very rare, but it's a very rapidly progressing disease. So this can lead to very severe disability or death within weeks or months of the outset. Luckily, this is pretty rare, but we do have these cases too. How do we diagnose MS? The more we progress into MS and getting to know more about MS, we do tend to rely a bit more on the clinical diagnosis. So we're looking for signs, symptoms, patient history, and we want to see as well their history of relapses and how the disability has been progressing. Yes, there are imaging examinations and periclinical exams, but they usually are more like an aid in the diagnosis. So we're talking about MR imaging of the central nervous system. We're talking about analysis of the cerebrospinal fluid. We can see visual evoked potentials, but we tend to rely more and more on the clinical diagnosis. There is also the 2010 McDonald criteria. This relies on current and previous symptomatic attacks, and it's an evidence of lesions seen on brain, spinal cord, MR imaging. So this tool actually combines the clinical and the imaging examinations. Personally, I haven't used it. I have done a lot of research about it. It seems pretty reliable. And it's interesting because, as I said, it combines both clinical and imaging together. So just to give you an idea, when we're talking about imaging, these are the plaques that you can see here. So these are the little lesions in the brain. And here I put one, I think it's kind of clear, but this is a lesion in the spinal cord. So we mentioned that we can see lesions either in the brain or the spinal cord. So this would be like just a little white line where the myelin is starting to become a little bit destroyed here, and likewise in the brain. I'll go quickly through this just so people don't get stressed that, oh, I have a symptom and for sure it is multiple sclerosis. There are different other infectious diseases that we could see with the same symptoms, talking about fatigue, paralysis, blurred vision, IBS, etc. So it doesn't mean just because we see all these symptoms, it is for sure MS. And that with time we see with the clinical diagnosis and the examinations, as we said, the imaging examinations. But a lot of other diseases or conditions that we can see do have very similar symptoms or signs to multiple sclerosis. It's just up to a healthcare professional or a doctor to actually do this differential diagnosis. Prognosis of MS, let's see. The prognosis varies considerably among individuals and for different forms of the disease. So we mentioned 8 different types of the disease. So we can't really say exactly what the prognosis will be unless we do take in consideration the time and how the disease is progressing. Between 10 to 20 of the percent of the patients have an indolent course of the disease with minimal disability over a period of 20 years. And approximately, as we said, only 5% of the multiple sclerosis patients do tend to have the more rare dominant disease, which they can die pretty soon. Sorry, the beep is because I'm at the clinic. I hope it doesn't bother you too much. Most patients eventually do require some type of mobility assistance. So we're talking either a cane, a walker, or a wheelchair. That progresses with time. And the life expectancy, when we talk about multiple sclerosis patients, could be reduced on average between 7 to 10 years. Treatment of MS, this is more my part now where I come into the whole equation. So 2 primary goals of MS treatment, we do want to see that we're trying to make the progression of the disease a bit slower, and we're trying to improve quality of life by relieving patient symptoms. We're talking about treatment for acute relapses, we're talking about management of chronic symptoms, and we're talking about treatment to modify the long-term course of the disease. So for example, people with MS, we really want them to be active as most active as possible, okay? Because if you just sit and don't do anything and the disease just progresses, you're not strong enough to be able to come back and be more active and keep your muscles working. So just an idea of the different types of treatments. Here we have drugs, obviously, and actually from what I'm aware of and from this research I've done, drugs are actually becoming stronger and stronger and better with time. So I'm not going to get into the pharmacological aspect of stuff because it's not my specialty. But people do tend to get drugs for the pain, for depression, for some laxatives when we're talking about IBS or bladder control. You can see here that we're talking about sexual dysfunction as well, or musculopsia or pain. Okay, so all these are controlled by medication. Then mostly we're talking about fatigue, spasticity, ataxia, tremor. We're talking about a multidisciplinary input. So we're talking about physiotherapy, we're talking about occupational therapy. We do need psychologists as well to take into consideration because we're talking about a very, very condition that can cause a lot of mood swings, depression. Okay, so all these we do need to take in consideration. Now let's go into a little bit more specifically about physiotherapy. So as a physical therapist, I'm sure I have some physical therapists with me today. We do take in consideration the assessment very strongly, okay? So we want to see the clinical signs, what we see, what has changed, what symptoms we have. So when we're talking about symptoms and lesions, we're talking about time and space. What does that mean? That means we're talking about how long have these symptoms been going on, and space is mostly where the lesion is. So is it in the brain? Is it in the spinal cord? In which area of the brain is it? How large is this lesion? How many deficits do we see? So all these we need to take into consideration, and that kind of helps with the prognosis of the disease too. Then we go into the evaluation part, which is the physical examination, obviously, and we want to see the history. We're looking at functional mobility. We're talking about exercise. talking about how mobile the person was before. Then we're talking about the cardiopulmonary function as well. See a bit the cardiovascular, what's going on there, how active again people have been before. And we also screen for risk factors. We're looking about respiratory and metabolic disorders, just to have an image, a complete image of what we're expecting to see, what we're expecting to, how we're expecting to follow this patient, and what needs to be attended to before something else. So maybe we have to fix their cardio before actually giving them more stressful exercises. So all this is taken into consideration as to how to continue with an MS patient. This is interesting if, as I said, I have any clinicians here. I found this, it's from an article. You'll see the references later. I tried to not put too many references in my slides because people can get a bit confused. This is a protocol I found that is really interesting when it comes to initial evaluation of the fitness, of the functional capacity of people, the cardiovascular capacity. So these, although in the paper it was actually more for the assessment part and the evaluation, this could also be used, as we know, as a rehabilitation program as well. So we can take like the 6-minute walk test, we can actually evaluate them at the beginning, see how they do, and then with time we keep doing it and seeing how they progress, how it changes, and they're following a program, right? Then we can see, like, let's say, for example, if we take the 30 seconds to stand test, then we put it again, we implemented it in the rehabilitation program, and we can see again with time how that varies, how that changes, how they improve or not. I'm not going to go through everything. Again, we were talking about range of motion because, as I mentioned before, we do see people who tend to get a bit more of spasticity or a lack of flexibility, or because of loss of muscle capacity or muscle strength, they start to become less and less weak and not going into ranges they usually go into. We want to see strength, power, muscle endurance. Endurance is very important when we're talking about MS patients, because if we see that they have small endurance, we need to keep strengthening and attending to that muscle endurance, because that also helps with their cardiovascular capacity, and they're able to do more exercise in time, which is very important, as we said, to keep MS patients more active and more functionally keep repeating the words, functionally capable to be able to do different tasks in their everyday activity. So I had mentioned before some of the impairments. I'm going to go a little bit more into the physical aspect of them. So as we mentioned, fatigue is the most common symptom we do see in multiple sclerosis patients. Then we spoke a little bit about balance. I also currently mentioned now muscle strength and endurance. Okay, flexibility, spasticity, cardiorespiratory fitness, incontinence, depression, and quality of life. Let's not forget that cardio exercise also helps with depression as well, because the more we exercise, the more our body produces endorphins, which also helps with us having a good mood. Okay, so all these in combination, cardiovascular activity, strengthening, help with all the above: fatigue, balance, muscle strength, etc. Let's see now the pyramids of physical activity and muscular fitness. This is more, again, for clinicians to give them an idea how they would go about with their actual rehabilitation program. So we always start with passive range of motion if people are not strong enough. This is for cases that are a bit more progressed, that are lacking a bit of that range of motion or active range of motion. So we go in and help them with their passive range of motion. Then we give them active flexibility and resistance exercises. We go into more specific muscle strengthening. So depending where they're more weak, If they're weak in their lower limbs and they're not able to walk, that's a bit more what we're going to focus on. And then we go to the upper limbs. And then we do an integrated strength training program. So it keeps them kind of mobile and keep that strengthening going throughout their life. On the other hand, we're talking about also activities of daily living. So we spoke a little bit more of the physical aspect. Let's go more into the functional part of it. We're looking about built-in inefficiencies. We want to get them back to their daily lives, right? So we do like active recreation, and then we have a structured aerobic training program. There is also virtual intelligence or AI, artificial intelligence, that people have been working on. I didn't choose to present it here because I think that's too much information, but a lot of people, and in the labs at McGill, there are many labs that have been working in artificial intelligence or visual artificial intelligence. So people tend to wear some, they're like big goggles, and then you can start rehabilitating. Like if you're walking out on the street and you're not able to keep your balance, or you don't have good reflexes or fast reflexes, they put you in this environment, a virtual environment, and then you can start avoiding obstacles and walking in the street before you actually go outside. And it's in a nice, controlled, safe environment. And I think that will progress a lot with time. I have worked on it personally myself in different occasions, and I think it's a very interesting approach to get back to being functional, risk-free. Okay, then for people who might be more in the kinesiology aspect of stuff, we want to make sure that our target heart rate is the following. Okay, so we don't want to get them too fatigued too fast, because what happens is a lot of people tend to overheat with multiple sclerosis. And we can see with this heat sensitivity they have, they start to decline, or they feel fatigued very easily. And then that could affect also their training or their rehabilitation or all these exercises that we're giving them, okay? Let's see now. Again, I have put a nice protocol for balance. Okay, so people who have problems with their balance, or they don't feel very comfortable, or they're not safe, or they have gait disturbances, we're talking about giving them different ways to retrain this balance. So we're talking about maybe walking forward in a tandem gait. That means one foot in front of the other. Or we're talking about walking over obstacles, over turns, or they can use their head and turn their head. And we're retraining their brain. We're sending a lot of stimulation to their brain to actually understand that, you know what, you shouldn't feel that you're uncomfortable, you shouldn't feel that you're imbalanced. So the more stimulation the brain gets, the more stimulation it receives, the better the body adapts, and it becomes more comfortable with when we put them in an environment that they will be receiving all these disturbances and obstacles. For example, here, exercises that proposed are, you can be naming an object while walking, or you could be talking and turning your head while you're walking, or these other exercises that I propose, like, for example, for cognitive retraining as well, because physio is not only about, body and strengthening muscles and targeting only the physical aspect of stuff. A lot of people tend to think it's only that, but we're talking about cognitive retraining too, right? So we could be telling them, recite the name and the days backwards, or the months backwards, or start subtracting 3 numbers from 97 and going backwards, or remembering things while you're walking. So we're retraining and the brain and the body. So we're sending a lot of stimulation to an MS patient like that. Now I wanted to talk a little bit about my clinic and how I work with my MS patients. I actually wanted to talk about a case study that I had at DYNAMIK. I had a patient who was a 33-year-old female, and she was diagnosed with multiple sclerosis in April 2021. She was also battling with lymphedema, but we were able to control that. What we saw in her history is that she had loss of force and flexibility in her lower extremities. She had a lot of difficulty with stairs and squats, but she didn't really have any other limitations. So we were talking about mostly the lower extremities. Her upper extremities were pretty good. She didn't have any loss of force. She didn't have any miscoordination. So we were really focusing on her lower limbs. Her functional status, she was quite active. She liked to swim 3 times per week. But the thing is that her walking was getting more and more impaired because of her episodes. And we did see that she did have some episodes once every, I believe it was every month, she had an episode. And after every episode, she did have difficulty walking or standing straight or keeping her balance. Luckily, she didn't have any history of falls. And what her goals were when she came to see me, she wanted to have a training program to increase and optimize muscle force in the lower extremities. This is, again, a little bit more technical and in my field. So her initial evaluation was in February, so almost a year after she was diagnosed. Okay, so we saw that she tended to walk a little bit with her knees inwards. She didn't, when she bended her lumbar spine, so when she did a flexion forward to bend to pick up something, she felt a lot of pulling at the end of range, so she wasn't able to get up easily. What we did is I educated her about multiple sclerosis, explained to her what she would expect to see, what her prognosis would be, how we would move forward from here, how the progression would be, and what to expect intensity-wise when she has the relapses. Just to give you an idea, on February 17th, so it was around 10 days after I saw her, she had a small relapse. She was unable to do squats. She couldn't heel raise. She couldn't lift her foot up, dorsiflex, and she couldn't even do a bridge when she was laying down. So bridge is when you're laying down on your back and you're trying to lift your bum up in the air. So what I did, I broke down these exercises to kind of make it easier for her, but with still the same goal. So instead of doing a full squat, she had to do 1/3 of the squat. And then if she lost her balance or wasn't able to keep it in a squat position, she could just sit down on the chair or the bed, wherever she preferred to be in. Then I put her again to sit down and then got her to just try and flex, so straighten her knee. Okay, so again, she's in a more controlled and safe environment, sitting down, so she doesn't have to be standing up in case she gets another episode and loses her balance or her muscle force. And I did try to tell her to try and continue to keep the heel raises with support on the wall. Usually I tend to tell them they can go into a corner, so corner wall as well, so they have support on both sides of the wall. Let's fast forward to 3 weeks later. She was feeling way better. She was gradually increasing her energy. We got to a point that she could walk up to 1 kilometer. And then I told her to try and go back to swimming again because I knew she liked it. I knew she had been exposed to that before multiple times. So swimming is a good exercise because you kind of alleviate gravity as well. So you have more freedom of movement. You do get a little bit of resistance as well from the water, but it's not a lot, but you're still retraining your muscles when you can't do it with weights or you can't go more aggressively into the strength training aspect of stuff. Then she had another small relapse. So I had to re-help her with her exercise again. We went back a little bit. So again, squats were getting a bit harder. Walking up to 1K was again a bit harder. She wasn't able to keep that stamina. that she was losing her muscle endurance. That's why I mentioned before, it is important to keep that muscle endurance, because even if you have a relapse and you start losing that muscle force, having that stamina from before will help you bounce back a bit faster. Then the last time I saw her was in April. Since then, she has been seeing other colleagues as well, because I'm getting busier with time as well. Last time I saw her, she was feeling much better. She had good progression of force. She was able to do up to 20 squats with no problem. Again, we got to 1 kilometer walking and pretty easily as well. Unfortunately, she is working and studying, so she doesn't have much time to go swimming. But our goal was after that to just keep increasing that endurance, building up her stamina more when walking. Our goal was to get past that 1 kilometer, get her to bike. Usually I do obviously tell them to do on a stationary bike, because again, if we have some issue with the balance, it's not super safe to be outside biking. So a stationary bike, I think she had one at home herself anyway. So that was a good controlled environment too. It's a closed chain exercise program too. So her limbs are quite well controlled in the pedals. So it's not something I was super, super worried about. And then swimming again when she had time, because the summer was coming up. So it's also a very good exercise. So some of the exercises me and my colleague Celine had given her, as you can see, is again heel raise, again with support. Try every strengthening exercise for the lower limb. So we're talking about the ankle joint, we're talking about the hip joint, we're talking about the knee joint. This is the bridge I mentioned before. We got to a point that she could do it with one leg, as you can see in the photo here, because initially she had started with both legs here. Then we got to a point that she was pretty comfortable with doing squats and balance. So we started on a balance board or a bassoon ball, the one that looks a bit like half a balloon. We got to a point that she was able to do double stance. And then at some point we did do a single leg stance as well. So with one leg, I was super happy with her progress. Last time I saw her here at the clinic, she hadn't had any more relapses. Her force is building gradually every time more and more. She's able to walk more. So it was a good case. It wasn't a super, super hard mess condition. She had very good progress. And until next time, I don't know what I'm expecting to see, because as we know, she will probably have another relapse at some point. But the more we're building her endurance and stamina and muscle strength in the times that we have this remission period, it will help when she actually comes to the relapses. So just to give you an idea number-wise as well, we're talking about force. So for my fellow clinicians here, she got to 4 out of 5 bilaterally, and then 4+ out of 5 bilaterally too. This we're talking about the hip, then the knee. She was almost okay, 5 minus under 5. Then we actually got to 5 out of 5. Ankle pretty much the same. So we can see from the start, it wasn't super, super bad, but the fact that we kept getting higher and higher will also only benefit her and help her in the future. And we managed here, I didn't really have any data for the balance because she wasn't able to balance herself on one leg stance. But last time I saw her, she was able to stay on her left foot for 5 seconds and on the right foot for 15 seconds, which is a huge gain and a huge win for me and her. So at the end, as I mentioned, I had everything I've put, apart from the case study, obviously, is based on references. These are the references if anyone is interested to look further into different studies, different papers. You're welcome to take a look at the references I used. And I don't know what we have here from what countries. I usually like to include thank you from every country. So thank you very much for your attention.